Okay, let's jump in. For our deep dive today, we're looking at something truly radical. It's a proposal from a physician with over 5 decades of experience, Dr. John Money.
And he's not just talking about small fixes.
Not at all. He's engineered a full blueprint to restructure the entire U.S. healthcare system. And get this, he promises almost free healthcare for everyone.
Right, which sounds impossible. But what makes this worth digging into is the claim behind it. We're talking about a plan that could potentially yield trillions in annual savings.
Trillions.
The whole mission here is to, completely dismantle the current system, to take control away from the government, away from insurance companies, and put it back in the hands of the consumer and the provider.
That structural shift is everything,
Mm.
because anyone who's dealt with the system knows the bureaucracy is just. It's crushing.
Mhm.
So our sources lay out this blueprint, and it's built on two main pillars, something called direct primary care, or DPC, and direct hospital care.
But before we get to the solution, we really have to understand the problem. I mean, the sheer scale of how broken the spending model is right now.
It's unbelievable.
It really is. The projections for U.S. healthcare spending, they're set to hit about $6 trillion in 2025.
$6 trillion. I mean, just let that number sink in for a second. That's 20% of the entire U.S. GDP.
And that's not just some abstract number. Per person, that comes out to over $16,000 a year.
16,000.
Yeah.
For every single person.
And if we were getting, amazing results for that money, maybe you could argue it's worth it, but we're not.
Not even close.
When you compare the U.S. to other industrialized nations, we have some of the worst health outcomes, lower life expectancy. It's like you're paying the price of a used car every single year for terrible results.
So why? Why is it so dysfunctional? Why doesn't $16,000 per person buy us good health? What's the fundamental flaw here?
It all comes down to the incentives. They're just completely broken. The whole fee-for-service model, driven by these third-party payers, it's designed to fail.
And Dr. Meany breaks this down, right? The three parties involved.
He does. You have the consumer, the provider, and the insurer. And the critical point is that none of them, not one, is incentivized to actually reduce costs. They're all pushed to increase them.
That sounds like a cost spiral that just keeps going up and up.
It is. It's exactly that. Consumers are paying these incredibly high premiums, so of course they want more services to feel like they're getting their money's worth.
Sure, makes sense.
And the providers, they're happy to do more because under fee for service, more services means more income. But here's where the real sort of systemic flaw kicks in with the insurance companies.
Okay, tell us about that structural incentive for the middlemen.
So under current law, there's a rule called medical loss ratio, the MLR. It says insurers have to spend about 80 to 85% of your premium on actual medical claims. But, and this is the key, they're legally allowed to keep the other 15 to 20% for their administration and profit.
So wait a minute. If their profit is a fixed percentage of the total premium, then they actually make more money when the premiums go up.
Precisely. You got it. If they raise your premium from $10,000 to $20,000, they have literally just doubled their own revenue for doing the exact same work.
Wow.
The system actually rewards them for making healthcare more expensive. So controlling costs becomes, well, it's economically impossible.
That insight is it's the whole foundation.
Yeah.
If the incentive is backward, the system will always fail. So let's talk about the waste, because this is where the money is just pouring out.
Oh, it's unbelievable. When you follow the dollar, you see it. So that 20% is skimmed off the top by the insurance companies for their overhead. Then another 10% just vanishes into hidden state taxes that are baked into the premiums.
So 30% is gone before a doctor even sees a penny.
Before they see anything. And then the providers themselves, they're forced to spend another 20 to 25% of their revenue just on administrative costs.
Just to handle the paperwork.
Just to handle the complexity, chasing claims, dealing with all the different insurance plans, fighting denials.
So if you add all that up, insurer retention, taxes, provider admin waste, you're saying that roughly 50% of every single dollar we spend on healthcare is not spent on care at all.
Exactly. It's not spent on your health. It's spent on navigating the financial maze we've built. And even the other 50% is filled with waste and fraud because there's no price transparency. The whole thing is broken.
Okay, so that brings us to the cure. The system is clearly sick. Let's talk about the solution.
And it's important to know this isn't just theory. This is coming from deep experience. Dr. Meany has 51 years in medicine, surgery, emergency medicine, and critically, he was an executive at an HMO where he actually managed to slash these costs. He adopted DPC himself way back in 2008.
So this is built on practice.
It is. The goal is simple. Eliminate the intermediaries, get rid of the insurance companies, the government bureaucracy, and create a system that's just hassle-free, affordable, and high quality.
So what does that actually look like?
It's a dual approach. You have direct primary care, DPC, for all your routine stuff, and then direct hospital care, DHC, for the big catastrophic things.
And the key is that the individual chooses.
The individual chooses their own doctor and their own hospital. No more networks, no third party telling you what's covered.
Let's start with BPC, the primary care side, because that's where you prevent costs from getting out of control in the first place. What does that look like in this new world?
You get unlimited access to your primary care doctor.
Unlimited.
Yes. All the stuff that's a hassle now, blood work, x-rays, ultrasounds, minor surgeries, women's health, it's all covered under one roof. It encourages you to actually go to the doctor and stay healthy.
So how are the doctors paid?
Yeah.
You can't be fee-for-service anymore.
No, that's gone. They moved to a simple capitated model. Each DPC doctor gets about $1,200 per year for each patient they enroll.
$100 a month.
$100 a month. And that covers everything. No claims, no copays, no deductibles for primary care.
But is $1,200 a year enough for a doctor?
It's a totally different game. Remember, they're not spending 25% of their time chasing payments anymore. All that administrative waste is gone. So that $1,200 is stable, predictable income, and they can focus just on their patients.
And no more of those skinny networks where you can't find a doctor.
Exactly. You'd have access to a network of around 450,000 DPC physicians across the country.
Okay, so that's primary care.
Yeah.
What about the other half? The big expensive stuff. Direct hospital care.
Right. So hospitals handle emergencies, inpatient care, major surgeries, and just like the DPC docs, they get paid a set amount every month for each person enrolled in their network.
So it's predictable funding for them too.
It is. But there's one crucial rule here, a structural mandate. Hospitals are not allowed to participate in primary care.
Oh, that's interesting. Why keep them separate?
It's all about keeping costs down. Hospitals have massive overhead, huge infrastructure, expensive equipment, all this bureaucracy. If you let them into the primary care game, they'll just absorb those DPC docs into their high-cost structure.
And drive up the price of routine care.
Instantly. By keeping them separate, you keep primary care lean, focused on the patient, and focused on prevention.
That makes sense. Keep the big guys focused on the big stuff. What about things in the middle, like seeing a specialist or getting an MRI?
Those would still be paid fee-for-service, a bit like how Medicare works now. But, and this is a big but, they'd be monitored very closely by the new funding entity to aggressively root out the fraud and waste that we see today.
Okay, funding. This is the big one. We're talking about getting rid of Medicare, Medicaid, the VA, Obamacare, all private insurance. How on earth do you pay for all this?
You replace all of it. All those fragmented programs, all the private premiums, they go away. Instead, you create a new independent healthcare fund.
And this fund is separate from politics.
Strictly separate. Its job isn't political. It just monitors quality and pays the providers directly.
So where does the money for this fund come from?
3 places. First, a dedicated healthcare tax, just like Social Security, paid by employees and employers. Second, states contribute based on their population, which replaces what they're spending now on Medicaid. And third, you fold in the medical parts of things like workers' comp.
Okay, but hang on. A new tax, that's where everyone listening starts to get nervous. Aren't you just swapping my insurance premium for a new government tax?
That's the key question. And the answer is no, because the plan is designed to offset it completely. You get rid of the premium and you get massive tax cuts.
What kind of tax cuts?
The proposal recommends no federal income tax at all for individuals making less than $100,000 or for families under $150,000.
That is a tectonic shift for the middle class.
It is. Think about it. If you're no longer paying, say, $20,000 a year in insurance premiums and your federal income tax is gone, the calculation is pretty clear for most people.
Okay, so let's connect this to the savings. What does this new system cost per person?
The projection is about $5,000 per person per year.
$5,000 compared to $16,000 now.
Right. So the total spend for the fund would be about $1.65 trillion a year, a huge drop from the $6 trillion we're heading towards.
That is an enormous difference. And that's before we even get to prescription drugs.
The drug prices are a huge lever. We spend over $350 billion a year now. Prices are often 10 times higher than other countries. The proposal says simply, allow drug importation.
And what does that one policy change do to the bottom line?
It's projected to drop our drug spending to less than $100 billion a year.
Okay, let's tally that up. You have the 1.65 trillion for care, plus the reduced drug spending. What's the final price tag for the whole system?
The total annual cost would be around $2 trillion.
2 trillion compared to 6. So the potential annual savings are nearly $4 trillion.
$4 trillion, yeah.
What does that even do to the economy, freeing up $4 trillion of waste?
It means that capital, which is currently going to administrative overhead, is now free. Individuals have more money, employers have lower costs. You'd expect to see real GDP growth, better global competitiveness, a huge economic expansion.
So tying this all together for everyone listening, what have we really described here?
What's really vital to understand is what this isn't. It's not a government takeover. It's not universal healthcare like a single-payer system. It's a system built on you, the consumer, being in charge.
And the government's role is what? A tax collector?
Pretty much. The government's role is just to collect the tax for the independent fund and then monitor it. They're a steward, not a provider.
Which brings us to the most provocative thought here, and it's something for you to really think about. The source material claims this whole thing, this entire massive transition, could be done in under 1 year.
It seems impossible, right? How can you shift a $6 trillion system that fast?
Exactly. But the source makes a fascinating point. The physical stuff, the hospitals, the doctor's offices, that all stays the same.
Nothing actually moves.
Nothing moves. All that changes is the financial plumbing. The new fund just starts paying the bills, and the old system stops. That one change flips the entire incentive structure overnight.
It creates competition based on quality and price and puts the consumer in control from day one.
It's a claim that just completely challenges how we think about policy change. That it has to be slow and incremental. The idea that we have everything we need already and it's just the flow of money that's broken. Well, it makes you wonder, is the real obstacle logistical or is it just political will?